Hello and welcome dear learners to the NPTEL course on Healthcare Quality Management, Infection Control and Patient Safety. In the Module 3, in discussion with Patient Safety Management, Infection Control and Medication Safety, in Chapter 29, we will be emphasizing in continuation with the discussion of infection control practices. The emphasis will be laid more on the importance of following infection control practices, prevention of central line associated bloodstream infection, and prevention of catheter-associated urinary tract infection. The importance of following the infection control practices, and what is the reason that if though we don't adhere to it, what happens? So, infection control practices are essential to break the disease transmission cycle. How it is done? It is done by interrupting the mode of transmission at some point in the chain. So you need to work on the chain, you need to think where you can break, and when you are interrupting this mode of transmission, you are able to successfully take the step in infection control practices. So proper infection control practices prevent infectious agent from leaving the source or invading a susceptible host. So two things are to be important: the source and invading a susceptible host. They help prevent post-procedure infection. You find lot of post-procedure infections are one which gives a major problem actually to the healthcare workers. Struggling with this, you can see that including surgical site infection, thereby ensuring safer, high quality healthcare services. So you need to see on preventing the post-procedure infections also. Adherence reduces infection risk, and adherence is very important among the healthcare staff, and adherence to this will see that they protect the wider community. The wider community from the patient to patient's relatives, the wider community outside when the patient is discharged, or sometimes even the healthcare employee. It can prevent them from infections originating in the healthcare settings. So you need to understand the infections are there across in the healthcare setting. So the importance or developing the culture to understand how to craft the infection control practices lie in understanding that healthcare settings are the one or reasons of originating of infections. Effective infection control minimizes the spread of antimicrobial resistant organisms. Antimicrobial resistant organisms are increasing a lot, and the complexity in treatment is making more chances actually to give us antimicrobial resistance. Even irrational use of antibiotics and medicines is also one among a reason actually for antimicrobial resistance organism. Modern infection control extends beyond patient's protection and also safeguard service provider, ancillary staff, housekeeping personnel, and the community from infections such as HBV, HCV, and HIV. Prevention is most cost effective than treatment and lowers the overall healthcare burden. So the emphasis is more on prevention because this is an area where you can really see that you don't have to put lot of efforts. By only taking proper planning, you can work on the preventive measures which can lead you to a very cost effective solution for this. There should be a rapid cycle audit plan. What is this RCAP? The RCAP involves daily monitoring. A daily monitoring is one which is a daily routine task for every healthcare employee actually to see that what are the key infection control elements. Where are those actually where you have to work on, such as environment cleanliness, hand hygiene compliance, indwelling lines and urinary catheters. So indwelling lines, urinary catheter, hand hygiene compliance and environmental cleanliness is the RCAP. The RCAP is one to be followed by everyone. So each day's audit allows quick infection identification of gaps and ensures timely corrective measures. So this continuous assessment strengthens adherence to infection control standard across all units. So you need to see that how you have started with the day 1, it should be continued with day 2, 3 and 4 and on. With respect to environment, with respect to hand hygiene, indwelling lines and urinary catheters, which is very important to be seen as this follows the rapid audit cycle plan, where whenever you have an issue with respect to any one of this, your team need to sit, discuss and identify the gap, work on the RCA and move ahead improving the infection control standards in your hospital. Now, with respect to prevention of central line associated bloodstream infection, that is called as CLABSI. So, the agency called as Center for Disease Control CDC and National Healthcare Safety Network, that is NHSN, they have recommended few important restrictions which can be seen as when you come across CLABSI reference to a serious bloodstream infection. This infection occurs when bacteria or viruses enter the bloodstream through a central line. So this is one very important way actually that the infection can go. And when you have to tackle this or prevent this, you need to set up protocols. You need to work on some standards. You need to work on the recommendations which are given by international agencies. And what are those? Those are like strict sterile protocol during insertion. It is very important that when you follow this strict sterile protocol, you will face maximum reduction into the rate of CLABSI. And daily infection control practices across the hospital and specifically in the areas where you are working in such procedures during the care are mandatory, which is to prevent the CLABSI. So CLABSI can occur where you may find central line associated bloodstream infections are becoming a major cause of morbidity, increased morbidity and mortality. Patient with CLABSI may develop fever, may develop redness, may develop soreness around the central line, where you may find sometimes requiring diagnostic tests and proper management actually to come across or to curb the CLABSI infection. What are the preventing guidelines for clinicians? The clinicians need to emphasize on this while they are working on such patients. Remove unnecessary central lines. Need to work on a chart which will emphasize to reduce actually the unnecessary central lines. Unnecessary central lines should be promptly removed. Tracking of this in terms of developing or trying to make a practice as a culture actually to see and check every day for unnecessary central lines. Perform daily audits to assess the continuing need for each central line. Whichever central line is needed or to be continued, you need to perform a daily audit for that. Follow proper insertion practices. And what are those proper insertion practices? Perform hand hygiene before insertion, which is according to the protocol given, which has been seen in adherence actually to the standard precautions which are being given by the organization, and adhere to all full aseptic techniques which have been taught into the previous chapter. Use maximum sterile barrier precautions. So what are those barriers? A mask, a cap, a gown, a sterile gloves and full body drape, which will reduce actually the maximum load actually for transmitting the HAIs. Use of 0.5 chlorhexidine with alcohol for skin asepsis before inception, which is very important. Select the optimal insertion site to reduce infection and mechanical complication. Avoid the femoral site in adult, which is one to be seen as a major reason of developing complications. Use sterile gauze or sterile transparent semi-permeable dressing to cover the site, which is very important that you are trying to see it as a insertion or standard insertion practices. Handle and maintain central line appropriately. which is a collective and a teamwork actually, where you can see in the leadership of the clinician you can strictly comply with hand hygiene before any line handling. Scrub the access port or hub before each use with appropriate antiseptic, chlorhexidine, povidone iodine, iodophor or 70% of the alcohol, which can be seen to be as one among the surgical scrubs. Assess catheters only using sterile devices. Replace wet, soiled or dislodged dressing immediately. Perform dressing changes using aseptic techniques, which can be seen as a proper handling and maintenance with related to central line. What are the recommendations for facilities? The facilities need to take very important steps to develop the culture. Empower the staff to halt non-emergent line insertion. If proper sterile procedures are not followed, don't put a pressure actually to see that insertions should be done without proper sterilization. Provide bundled supplies, that is in kits, so items are readily available at the point of care. Ensure checklist for insertion and maintenance practices are given to clinicians and followed consistently. They need to work on the checklist part and even to see that they are adhering actually to those practices which are being taught. Maintain easy access to hand hygiene system, which is very important because many times it is being seen that the healthcare workers don't follow only because the access is the problem. Also see that compliance. So monitor the compliance and give prompt feedback to improve the adherence. If you find there is a lapse, you ask them actually with respect to the feedback what needs to be done and what needs to be improved. Conduct recurring education on insertion, handling and maintenance of the central line, which is very important for every healthcare workers who are working in these restricted areas. They need to have a thorough education and they need to update their skills if there are any lapses actually for their part, especially on insertion, handling and maintenance of central lines. These are some precautions actually with respect to take care and to understand how the prevention of CLABSI is done. Preventing guidelines for clinicians, where remove unnecessary lines, follow proper insertion practices with respect to hand hygiene, maximum sterile, barrier precaution, chlorhexidine, skin antisepsis, which is very much being seen visible in this portrayal, and then handle and maintain it appropriately, which is very important, where you find a strict hand hygiene before handling, scrub, access to port and all that is very important. So this can give you a proper set of checklists that if you have done all these steps, first, second and third, in prevention of CLABSI, you will find maximum reduction in the rate of these CLABSIs. Then comes prevention of catheter-associated urine tract infection. You may find number of incidences in your institutions have witnessed because of not taking care of the catheter associated in urine tract infection. It has been seen as a very contributing cause actually to increase the HAIs. The agencies as Center for Disease Control CDC and National Health Safety Network NHSN recommendations, which are divided into two categories. One is of the basic practices and the second is of special approaches. The basic practices that should be implemented by all acute care hospitals, which has a huge load of acute diseases. Special approaches that can be used in specific locations or population of patients when HAI remain uncontrolled despite basic practices, especially for tuberculosis or HIV or cancer and other institutions, which are tackling it as an unit or sometimes as a specialized hospital, where you need to develop on particular wards or hospital a special approaches versus to the basic practices. The basic practices are those where the benefit of reducing HAI risk clearly outweighs the potential for undesirable effects, where you may find the benefits of that and you may see in the reduction with the help of the hospital statistics with respect to healthcare associated infection. Special approaches are used when an intervention is likely to reduce HAI, but there is no uncertainty. Or sometimes you may find that you are not really going to the depth of the cause and the cause is really still pending, like regarding harmful outcomes, limited evidence, or benefit only in certain settings. Mostly, the example can be cited during the outbreaks or selected patient groups who come up with a specific healthcare or hospital acquired infections. Hospitals should first prioritize implementing on the basic practices and slowly they should try to emphasize on going on the next level, as these provide the strongest and the most consistent benefit. If HI surveillance or the other risk assessment show ongoing opportunities for improvement, hospitals should adopt some or other special approaches. That's the reason I'm saying going from basics towards the special approaches. HI surveillance plays a major role actually in assessing the risk, because if you are not able to assess the risk, how you will be able to actually to improve the practices. The special approaches may be implemented in specific units or hospital wide, depending on the outcome of the data. What is the data? On that basis only special approaches can be planned. Risk assessment can be done, and according to the local requirements you can work on this. So remember that each CAUTI prevention recommendation is supported by quality of evidence grading system. And if you are putting this in practice, actually you will find maximum reduction in catheter-associated urine tract infection. What are the recommendations for preventing and monitoring CAUTI? So this would be very important for those hospitals or institutions which are having a huge load or are on verge of developing a huge load of CAUTI. This is one among the HAIs actually which put lot of efforts for the institution to curb. So what are the best practices for preventing CAUTI? It is provide appropriate infrastructure. Implement written guidelines for catheter use, insertion and maintenance. So catheter use, insertion and maintenance, they need to know through a written guidelines. A hospital should either have their own guidelines or they should follow a national or a state level guidelines. Develop and implement facility criteria for acceptable indications for indwelling catheter use. So if you don't have a facility criteria, it is very difficult actually for acceptable indicators to understand, and through this you will not be able to even get a proper idea. Ensure only trained and dedicated personnel insert urinary catheter, because it is a very dedicated task actually where you can find the trained and skilled people only should do it. Also the persons actually who are put into this task, they ensure the sterile supplies for aseptic catheter insertions are available and accessible, where you need to work on those. Also along with that, maintaining the documentation for the catheter placement. When the physician has given the order, what is the date, what is the time the insertion has been done, who is the patient, who is the inserter, the daily presence, care task and removal justification. So all this will be done in the guidelines, in the guidance of the physician by a person who is doing, or healthcare workers who is inserting it as well as removing it. Ensure adequately that trained personnel and technology for surveillance of catheter use and their outcomes, which is very important to improve the practices. The people who are into this or those who are devoted to work on the technology for this need to be adequately trained. Conduct quality surveillance based on facility risk assessment or regulatory requirements, because sometimes you may find that some of the facilities may have more versus to other may be having a lesser actually of load of this infection. Identify patient groups or units requiring surveillance based or catheter use frequency and risk level, that is according to the type of surgery or obstetrics or critical care, because these are the three major areas where you may find that lot of CAUTI infections comes with. What needs to be done in the next line? Provide education and training. So educate the healthcare personnel on catheter insertion, care, maintenance and alternatives to catheter use. Assess and verify competency in catheter care and insertion technique. If you do find that there are lapses or lag, you even provide them more education or give them a proper training. Use appropriate training for catheter insertion. This can be done only by monitoring. Insertion unit catheters only when indicated and remove them as soon as possible to avoid infection more. Perform hand hygiene immediately before insertion and after, where you may find lot of those components actually which are connected with catheter are more chances of giving even a hospital acquired infection to the patient as well as to the healthcare employees. Follow strict aseptic technique as using sterile gloves, sterile drapers, sterile sponge and sterile equipments. Clean the urethral meatus with antiseptic solution. Use a sterile single-use pack of lubricant jelly while you are inserting the catheter. Use a sterile or aseptic solution for cleaning the urethral meatus before insertion, which is very important to be emphasized to the training part. Whenever you are conducting training or you are giving training, try to see that all these points are covered over there. Use the smallest appropriate catheter size to minimize the urethral trauma, which will reduce actually a pain to the patient, where versus the participation of the patient will be more in this procedure. Then comes ensuring proper management of indwelling catheters. When already you find that securing the catheter properly to prevent movement and urethral traction, because many times movement assist can be one of major reason actually that you can get more chances of developing infection. Maintain a sterile, continuously closed drainage system at all times whenever the drain is to be done. Replace the catheter and drainage system aseptically if you find that there is a contamination, disconnection or leakages occur, which are the higher chances actually with respect to patient who have a maximum movement. Collect fresh urine aseptically using the sampling port for disinfecting it with an appropriate agent. Obtain large urine volumes for special analysis using aseptic technique directly from the drainage bag. What needs to be done? Maintain obstructed urine flow in the drainage tubing. Perform routine hygiene only. Do not clean the metal area with aseptic solution unnecessarily, which will also create a antimicrobial resistance actually. Then comes automated or electronic reminder system. Does it really works? Yes, it is. Use automatic stop orders or reminders to reassess catheter necessity based on agreed criteria. Use standardized electronic or paper reminders for persistent catheters to alert to the clinician, which will give you alert. The physician will work on that, will give guidance to the healthcare workers and they will work on in the next level. Nursing and physician staff must conduct daily reviews to determine if catheter use should be continued or not. Additional management protocols can be like implement protocol for managing post-operative urine retention, including intermittent catheterization and bladder scanning, which will see that if there are any progressive sign or even reduction sign can be monitored. Establish a system for CAUTI data analysis and reporting, including unit-specific feedback for quality improvement. Now we will see what are the special approaches for preventing CAUTI. Implement facility-wide programs to identify and remove unnecessary catheters using proven effective methods. So what needs to be done? Develop institutional policy, which is very required usually in daily, which can review of catheter necessity and discontinuation, which is one time that many times they are struggling actually with the healthcare workers actually, and then they are constantly talking to the physicians and clinicians and making them special request from the patient, or even many times they also find that this should be discontinued. So what are the approaches? Approaches not recommended for routine CAUTI prevention. Do not routinely use antimicrobial or antiseptic impregnated catheters. Do not screen or treat asymptomatic bacteria except before invasive urological procedures. Avoid bladder irritation routinely. If irrigation is needed for obstruction prevention, maintain a closed system. So there might be Unresolved issues in CAUTI prevention. Yeah, many times it has been seen that. So no clear evidence favoring aseptic solution versus sterile solution for metal clearing before insertion. Insufficient evidence for urinary aseptic like methamine to prevent UTI. Limited evidence supporting catheters with walls. Unclear benefit from spatially separating patients with catheters to prevent pathogen transmission. And then you can work on antimicrobial prophylaxis at catheter removal to prevent symptoms of infection remaining, unsupported by a strong evidence that can give to the patient even after removing the catheter. So these are few recommendation strategies for CAUTI prevention, which starts from infrastructure, education, insertion technique, management, reminder systems, and additional protocols that we have seen in the previous sections actually, which describes to give you more chances of CAUTI prevention. These are some additional precautions actually which we can see when you are doing or working on CAUTI, where special, not recommended, and unresolved approaches, where you sometimes find you have to do work on special approaches, facility wide program that you have to take it. Not recommended are routinely use antimicrobial impregnate catheters, and unresolved issues, as sometimes we may find that there are many issues you have to work with antimicrobial prophylaxis at a removal. So these are in aligned to the previous discussion for this part. So in the summary, I would like to emphasize more that CAUTI prevention strategies are grouped into basic practices for all hospitals and special approaches only for settings where infection persists despite standard measures. So basic versus specific approaches you need to prioritize, and special approaches are used when evidence is limited. Evidence is limited with respect to the risk are uncertain. So benefits apply only in specific units or during outbreaks. So lastly, I would say hospital should use surveillance and risk assessment. It will give you what to determine when additional special approaches are needed. So thank you for the patience listening, and try to emphasize that your organization need to work on developing when they are working on the CAUTI problem. Thank you very much.